Hi everyone, thank you so much for joining us today for our FLS Works webinar. Today our topic is what patients have told us, implications for FLS and the care gap. Just a little bit of housekeeping before we get started. Again, I'd like to thank you all for joining us today. The recording of this webinar will be available on the FLS Hub once we finish, and the slides will not be available for recording. So the FLS Works series launched in the spring of this year, and this is our 4th webinar in the series. So our speaker today is Joanna Sale, and I'll introduce her a little bit more. She's the scientist from the St. Michael's Research Group in musculoskeletal health and outcomes research. So her webinar today is going to be 40 minutes long, and afterwards we'll have time for questions. As we're going through the webinar, if you have questions for Joanna, feel free to type them into the chat box or the question box, and I'll see those questions. We'll save them for the end for Joanna. And if for whatever reason there's more questions afterwards, you can always email them to me as well. So without further ado, I'll introduce Joanna. So Joanna, again, like I said, is a scientist in the musculoskeletal health and outcomes research group at St. Michael's Hospital. Interests are in evidence to care gaps in musculoskeletal conditions, especially medication use, the patient perspective, older adults, and behavior change. Joanna's connection to Osteoporosis Canada's FLS work is that she co-leads the evaluation of the fracture screening and prevention program within the Ontario Osteoporosis Strategy that is funded by the Ontario Ministry of Health and Long-Term Care. Thank you so much for the webinar for us today, Joanna. So I'm going to pass it to you now to get us started.
Great, thanks, Katie. Am I able to advance? Matthew? Great. Thanks for the introduction. As Katie mentioned, my name is Joanna Sale. I'm a scientist at St. Michael's Hospital, and I also have a faculty appointment at the University of Toronto. Thank you to all of you for taking the time to participate in the webinar today. I also need to thank a lot of programs and organizations with which I have been involved with over the years, as well as people, including the amazing interviewers on the different studies that we've conducted, the recruiters for those studies, co-authors, and others that we have collaborated with, including the evaluation team at St. Michael's Hospital. Just a brief introduction to say a few other things about myself. I am a clinical epidemiologist by training, and I am embedded within 2 FLS programs in Ontario, the Ontario Osteoporosis Exemplary Care Program at St. Michael's Hospital and the Fracture Screening and Prevention Program. So these 2 FLS programs cover 37 of the 45 FLS programs in Canada. And I've collaborated with a number of groups, including Osteoporosis Canada, the International Osteoporosis Foundation, and the Fragility Fracture Network. Other than that, I have no conflicts to declare. So today, for the first half, I'm going to be talking about patient perceptions and experiences, and that includes their behaviors in relation to bone health in general. And then I'm going to be talking about perceptions and barriers to treatment and how these relate to the adherence literature. And then I'll close with implications for FLS and the care gap. I wanted to just point out a few things before starting. Most of the work that I'm going to be talking about is from the patient perspective and their perceptions of and experiences with healthcare providers, but it is from the patient perspective. I'm going to do my best to speak on behalf of patients, but I am not a patient myself. I'm going to be focusing on qualitative research, so insights from the various studies that we've conducted over the years. So I'm not going to go into very many details, but more so we'll talk about take-home messages. The majority of the patients I'll be talking about today are patients with a fragility fracture, aged 50 to 89 years old, and most of them have been screened through an FLS program. I think there were 2 studies where patients were not actually screened through an FLS program. And I'll be talking about their perceptions of medication in general, but I'm not going to be talking about specific medications. And some of the work is in progress. Other work has been published, and that will be noted in the slides. The sources of our data come from a variety of areas. One is the Osteoporosis Exemplary Care Program at St. Michael's Hospital, which has received the highest rating from the IOF for excellence in implementing best practice guidelines in post-fracture secondary prevention. We've got 2 publications in JBJS, one just this year on outcomes of that program. Patients screened through the fracture screening and prevention program is another source of data, and the FSPP includes 36 sites across the province of Ontario with 8,000 patients screened annually, and we have published a number of papers on the positive outcomes of that program, including increased medication initiation over previous versions of the program, as well as the cost effectiveness of the program and how it's decreased gender inequity. We've also interviewed patients through the Canadian Osteoporosis Patient Network, which is an osteoporosis patient group where members receive information and interact about osteoporosis-related interests in a virtual environment. And then finally, we did a study through Osteoporosis Canada where patients were prescribed medication, they attended an education session, and then they were provided with an education booklet. So before we talk about the findings, in general, what do we mean by the care gap? I like to show this slide. Depending on your FLS, a patient may need to do the following after they've had a fracture. They have to go to their GP and or their specialist. They have to go, assuming that they get a referral, they have to go to their BMD. They have to return to their GP or specialist for the results of that BMD. They have to understand those results. They need to receive a prescription. They need to fill that prescription. They need to pick it up. They need to decide to take the medication. Then they have to take it. They have to experience no side effects or side effects that makes them change their mind about the medication. And this is all assuming that there is equity in their accessing the healthcare system. So our group has been interested in all of these steps as they relate to adherence and medication use. So why do we care about the patient perspective when we're looking at the care gap? Well, we know that patient values, their beliefs and preferences are fundamental tenets of evidence-based practice, as well as the development of clinical practice guidelines. However, some of the work that we're doing currently demonstrates that patients are rarely represented in osteoporosis guidelines, especially as we understand the word preferences and values. And I'm going to talk more, the guidelines tend to talk more about whether patients prefer drug A over drug B, rather than a broader definition of what their values and preferences are. So what are their perceptions and experiences? I'm going to talk a little bit about the burden of fractures. Fractures, we've found, make you old. Fractures don't necessarily happen to old people, but they make people old. I feel like I'm 80 years old, not 53. I used to be unbelievably active. The walker, makes me feel old. And patients have told us that they don't like that bone health education happens in quote-unquote old age homes, which also makes them feel old. Fractures cause long-term pain and limitations. Few studies have examined pain beyond 6 months of a fracture. And in one study, we found that over 2/3 of our patients reported fracture-related pain and or limitations beyond 6 months. In another study, we found that 43% spoke about post-fracture pain unprompted, so we didn't ask about pain at all, and most of that was beyond 1 year. So for example, I still had a problem raising my arm in a certain direction. Because of the wrist, I can't change the sheets on the bed. And this was found with patients, not just those with vertebral fractures, as has been shown in the literature. In fact, 75% of the patients in one study did not have vertebral fractures. And this pain is unrelieved and generally not treated by healthcare providers. We've also found that fractures make you fearful, and many of our individuals that we recruit for our studies worry about falling. In my mind, I feel very scared to fall again because I can imagine it'll be worse. You realize another fall could be fatal. What about perceptions of bone health? We found that ambiguity persists despite patients being educated through an FLS program. So they have confusion about the cause of fracture. And in one focus group, we noted the following interaction. One person said, "I can see if you break easily, but if you slip on the wet floor," and another participant ended that sentence, "Anybody would have broken something." Patients have ambiguity about the presentation of osteoporosis as a disease. So they'll say things like, I have some pain in my leg, and right away my thoughts were, am I going to break my leg? They have ambiguity about the BMD process and results of the BMD. I don't understand because it was my wrist and ankle that was broken, and they, the technologist, checked my back and my hip. Patients express ambiguity about the amount and type of medication. So in this particular study, 20 of 24 patients talked about having ambiguity about medication, in that they didn't know that medication could be combined with supplements. They confused supplements with medication. For example, I had started on a whole bunch of calcium, like alendronate, ended up on risedronate. They don't know how long to take the medication. If you're feeling better, you're more inclined to continue. If you feel worse or you don't see any change, then you'll stop the medication. We've also found that half of patients that we deemed as high risk find the decision to take prescribed medication difficult. So approximately half of patients make that decision with minimal contemplation simply because they liked or trusted their healthcare provider. But the other half of patients find the decision difficult and they need to be convinced. So they often engage in a risk-benefit analysis. They use other sources of information, such as friends, family, the internet, and they are very concerned about side effects. We've also found over and over again that patients do not link their fracture to bone health. So sustaining a fracture by a patient is perceived as a traumatic event, both physically and emotionally. The fracture is often described as a freak or a fluke event, and they use forceful, action-oriented words to describe the fracture. They talk about going up in the air, flying, crashing, popping a pelvis. I sort of hurtled forward. I flew into the elevator. I shot out of a catapult practically onto the sidewalk. And this study was done back in 2012, and we continue to hear this story. I was just coding a transcript last week, and here's what this individual said to us. I tripped really quite violently, like went flying, and I had to kind of change direction because there was a young woman in front of me, and I didn't want to crash into the back of her. I was sort of airborne, and I landed hard and skidded headfirst into the side of a building. We've also looked at patients' perception of risk, and in one study we conducted an intervention where we relayed fracture risk to patients and healthcare providers, and we used 3 communication strategies to relay fracture risk. We relayed it verbally, we told them they were high risk, numerically, and we showed them the CAROC graph. That's on the Osteoporosis Canada website. And we found that in general, patients overestimated the percentages corresponding to fracture risk, and they had very poor recall of the graph. I believe 3 individuals remembered the graph at all. And of those who recalled being high risk, so 81% of our participants recalled being high risk for future fracture, approximately half did not believe it applied to them. So they said things like, they, the physicians, tell everybody that. If I lived my life thinking that way, then I wouldn't be living my life. I think she, the screening coordinator, overplayed the risk. This fall, to suddenly trigger high risk, I'm saying, sorry, no, I just think there is a leap in logic. And when we asked them about fracture risk in more detail, it became clear that they weren't exactly sure what they were at risk for. So they talked about being at risk for osteoporosis, for being at risk for low bone density, for falling, for fracturing if they fell, harm from an additional fracture. They were at risk for certain types of fractures, for example, a hip fracture, but not others, such as a wrist fracture. And they were at risk for fracturing under certain circumstances. So more at risk outside than inside, more at risk if they fell on a hard surface versus a soft surface, if they fell forwards rather than backwards, and generally in just doing certain activities. But patients may not be the only ones responsible for the care gap, and we've done some analyses of what patients have told us about interactions with healthcare providers. And we found that providers may use incorrect heuristics to make clinical judgments. So patients have told us that they were told that they were overweight, so they didn't need a BMD. They were from a particular ethnic group, so they didn't need a BMD test, or that they were too young or too old for a BMD. In general, family physicians are perceived by some patients as not interested in bone health, despite patients presenting with height loss, being high risk, presenting with a vertebral or multiple fractures, or having a family history of osteoporosis. And compared to family physicians, specialists were perceived as more interested and knowledgeable. They took the time to discuss bone health with them, for example, the different treatment options, and the specialists were also more persistent with recommendations. We found that there's also appears to be inconsistent messages within and across healthcare providers. So, for example, one patient who had two different family physicians, the first family physician looked at her x-rays and said, oh, no, 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 everything's fine. Whereas the second family physician she went to looked at the same x-rays and said, oh my God, it looks like moths chewed at your bones. So what are people actually doing? We've talked a little bit about their perceptions and their attitudes, but what are they're doing about their bone health? We found that fractures make you cautious and vigilant. So 20 of 21 patients in one study noted that they monitor their actions with a greater degree of vigilance. I'm just careful how I walk around. I walk more slowly on the subway. I try not to be on the subway at rush hour. I always hold handrails and I'm wearing proper shoes. I look at the sidewalk and I know where the ridges are. I don't lift heavy things. Patients report using non-pharmacological strategies as well for bone health, including exercise, having a healthy diet, and taking supplements, as well as using aids and devices. They report to us that the recommendations for non-pharmacological strategies are received from healthcare providers, but also from family, friends, the media, and the internet, which may actually be more influential than healthcare providers sometimes. In another study, we classified individuals as effective consumers based on their behaviors, and we found that people we classified as effective consumers made requests of their healthcare providers for things like referrals to bone specialists, referrals for BMD tests, and referrals for prescription medication. We've also found that there may be some differences in management of bone health between men and women. And we did one study, because our studies generally don't have a lot of men in them. We did a secondary analysis combining a number of data sets to look at men's health-seeking behavior. And we found that men with a wife or a female partner described these women as playing an integral role in their bone health management. For example, helping them with their medication regime and removing tripping hazards in the home. We also found that men described taking risks, such as drinking alcohol, climbing ladders, or simply refusing to take their medication, more so than what we've found with women. And men appeared to not dwell on the meaning of the fracture and or bone health. So how might perceptions and experiences of patients relate to treatment? But first, what are some of the care gaps related to treatment? So I'm going to start by talking about the adherence literature as it relates to treatment, because I think it's important to sort of have some background information about that. We know that about 50% of patients are adherent to their medication regardless of disease, treatment, or age. And this is similar to data that we found on osteoporosis medication. The term adherence is a complex term. For one, it's a pharmacological intervention. That's a behavior added to people's lives rather than a modification or an elimination of existing behavior. So that makes it a little bit complex. How adherence is assessed and defined is also quite variable. So, for example, medication possession ratios are used with different cutoffs. People talk about compliance versus persistence versus adherence, where compliance has to do with correct dose and frequency. Persistence has to do with how long a patient goes without a permissible gap. And adherence is a combination of those two terms. We found that the timeline of persistence, if you're looking at persistence, varies. So there are different durations in the different studies, showing basically that persistence with osteoporosis medication decreases over time. For example, Burden and colleagues in 2011 showed it was 63% at 1 year, 46% at 2 years, and then 12% at 9 years. The denominators that are used are often different or unclear, which adds, I think, to the problem. And there are stages of adherence. 30% of individuals do not pick up their osteoporosis medication. 10% fill only a single prescription. People stop and restart their medication. So Brookhart in 2007 reported that 30% restarted their medication within 6 months, 50% restarted within 1 year. And some people have tried to categorize adherence versus non-adherent. For example, it's been described as erratic versus unwitting versus intelligent, where erratic refers to a person not being able to establish a pattern of adherence. Unwitting adherence refers to where you think you are adherent, but you aren't. And we think that this may apply to non-pharmacological treatment with osteoporosis, and I will talk a little bit about that later. An intelligent adherence is just when people are deliberately non-adherent. Nikki Britton from the UK talks about adherent individuals versus self-regulators, where self-regulators she describes as individuals who have an aversion to medicine and they don't tell their healthcare providers this, but rather use alternative strategies rather than taking their medication. Then there's this concept of medication initiation, which is not really about adherence unless you know who actually was prescribed medication. And in one systematic review, we found that 22 to 34% of fracture patients initiated osteoporosis medication after a post-fracture initiative. And in our own program, the fracture screening and prevention program, we found that patients participating in the BND fast track of our program, which is now usual care, a very highly facilitated group, we have up to 47% of them initiating medication. Some authors have tried to look at predictors of medication adherence in bone health. So, for example, when predicting initiation, being female, being between the age of 55 to 74 years and having less than or equal to one comorbid condition is a predictor of initiation. When we're looking at persistence, being female or having prior fractures has been found to predict whether or not people are persistent with their medication. However, the demographics of individuals don't seem to explain very much when we're looking at adherence. So McCombs in 2004 talked about demographics explaining 4 to 6% of persistence, and Solomon in 2005 reported 6% of compliance was explained by demographics. Last year, an individual asked me about personality types and whether personality predicts medication adherence, and I haven't been able to find any literature on that. So I think that would be a really good study for someone who is interested in looking at. So the bottom line from my perspective is that adherence or medication use is not a binary concept, and I actually prefer the term medication use. So going back to our second objective, how do patients' perceptions, their experiences and barriers relate to treatment adherence and the various aspects of treatment adherence that we've talked about? And I've just informally classified perceptions, experiences, and barriers into the following topics, and then I'm going to weave them into how they perhaps relate to treatment or medication use. So what about knowledge about treatment, including knowledge about medication? Our early work with patients who expressed ambiguity about treatment led us to examine knowledge as a potentially linked variable with medication use. So in one study, we had 50 community dwelling participants who were prescribed osteoporosis medication. They attended an education session and they received an educational booklet. And we found that 28% of these individuals were not on medication at the time of the interview. 3 had never started, 9 had stopped, and 2 were on drug holidays. And this is despite having been prescribed medication and received education in 2 different modalities. We, in our study with the Canadian Osteoporosis Patient Network, we looked at effective consumers who we assumed had a lot of knowledge about medication, and they described a number of strategies to navigate for care after a fracture. They requested prescriptions for general or specific medications. They actually requested switching medications over the years. And they did research on the different medication options or the actual medications that had been prescribed by their healthcare providers. But being an effective consumer was not associated with current medication use. 56%, so just over half of these patients, or individuals I should call them, were taking medication. What about the decision to take medication? So remember we talked about a study where we looked at high-risk patients, and half of them found the decision to take the medication difficult, and they needed to be convinced to take it. And regardless of whether they were taking or not taking medication, most of those finding it difficult to make that decision in the first place indicated that their medication status might change at a later date. Healthcare providers may also affect medication use. And it may be that healthcare providers don't always prescribe medication appropriately. For example, one moderate risk patient who was 56 years old was told that everything was fine, but that she should start taking antiresorptive medication as a preventative measure because of her age, 56 years old. Whereas another moderate patient who was 50 years old, so similar, was told that there were medications for prevention, but these medications were for very old people. So basically similar types of patients, but with different recommendations. And conversely, one high-risk patient who would have been indicated for pharmacotherapy was told, my physician told me to lose weight. She said it would be easier on my bones, rather than being prescribed medication. Healthcare providers may not agree with each other about medication prescription. So one patient with two specialists told us that her gynecologist was pushing the medication too hard. He kept saying, it's your choice, but I think you should be taking it, the medication, whereas her rheumatologist did not think that she needed medication because she did not have osteoporosis. She was in a gray area, and that her bone density had leveled off, and that these drugs were not bone builders. What about perception of bone health? I don't believe that medication use is associated with perception of bone health. So approximately half of patients who report their BMD test results were normal or not serious were taking osteoporosis medication anyways. And what if we look at whether patients connect their fracture to bone health? Remember I was saying that study where 83% of patients described their fracture as a freak or fluke event. For example, if I had fallen another 90 degrees to the left or 50 degrees to the right, it wouldn't have broken. 60% of those describing their fracture as a freak or a fluke event were taking osteoporosis medication. What if we frame bone health status in the language of fracture risk? And so going back to the study where we told patients verbally, numerically, and visually that they were high risk for future fracture based on CAROC 2010, the one half who recalled being high risk but did not believe that this risk level applied to them, 70% were still taking osteoporosis medication. Attitudes and beliefs, and this is sort of based on some work that we're just doing right now. But we have found that few patients speak about medication as reducing fracture risk. They talk about it as improving or maintaining bone density. It's helping the bone to maintain its level of density. As well, medication is sometimes perceived for pain relief. I can feel a difference when I take them. So that's beliefs about the medication and what it's for, whereas I think that belief in the medication may be more important, especially when you're directly asking about the effect of the medication on fracture risk specifically, because patients will then say, I think they decrease my chance of having a fracture. Hopefully it decreases it. The medication alone is not enough. It's supposed to be decreasing it. It should decrease the chance of me having a fracture. I don't know how that medication is going to help me. What about patients who fracture while taking osteoporosis medication? Do they believe that the medication failed them? Again, this is based on some preliminary analyses, but in general, patients do not stop taking medication even when they fracture while they're on the medication. And they'll say things like, something is making my body not absorb it. My endocrinologist will figure it out. I guess luck of the draw. It's a fracture was a pure accident. Again, that's a very common response. It's because my bone wasn't strong enough because I did not take the right medication for osteoporosis. I just felt I needed to do more. I needed to be more alert, to do more exercises, to do the right exercises. And we found individuals blaming themselves for skipping doses or that they weren't on the medication long enough. For example, they had to be on it for 5 years, or that medication is even more important now that they have fractured. And we don't have a lot of data on patients who are fractured during a drug holiday, but even when an individual is fractured during a drug holiday, the medication is not considered as failing them either. And we had one patient that said to us, that medication is in your system and lasts for a while. What about patients who are high risk and then they experience, on top of that, persistent pain at the site of the fracture? Is pain a reminder of the fracture and an additional motivator? And in the one study where we found over two-thirds who reported fracture-related pain and or limitations beyond 6 months of fracture, 67% were taking osteoporosis medication. And focusing on the 24 patients who reported pain 1 to 13 years post-fracture, another study, 60% were taking medication. Non-pharmacological treatment. So we've already talked a little bit about how patients use a variety of non-pharmacological strategies, including being careful and exercising and having a healthy diet and taking supplements. But these strategies do not appear to be related to current osteoporosis medication use either. And let's just focus on diet for a couple of slides. To me, the relationship between diet and supplement use is not really clear. The association between that and medication use. But we have found there is a challenge when talking about or relying on non-pharmacological treatment, because individuals will consistently tell us that they get enough calcium and vitamin D through diet and or supplements. But when you start asking about specifics, they'll say, I eat eggs, I like a lot of vegetables, I do love oranges, I try to have a serving every day, I have strawberries and blueberries in the morning, I make my own homemade soup, I don't buy too much of that stuff on the shelf with all the additives in it. Stews and chicken, plain, solid food. They often talk about what they are not doing, which is sometimes related to the comorbidities that they have. So, for example, they say they don't have any fat in their diet, no salt, no alcohol, no sugar. I'm diabetic, so I don't eat a lot of baked goods. Or they will apologize for what they're not able to do because of comorbidities. And one participant talked, or one a woman talked about her husband and said he's not allowed oranges because of the kidneys. And in general, I think individuals may be consistently below the recommendations for supplements, especially calcium, based on some preliminary analyses that we're doing. So to summarize up to this point, there is some confusion about bone health in general and the management of bone health. Approximately half of our patients appear to defer to their healthcare provider in the decision to take, and the other half find it really difficult. Across the board, patients are concerned about perceived and experienced side effects, and those are two very different things, perceived versus experienced. Patients still do not link the fracture with bone health, and unfortunately I don't have any answers, because I think that medication use is not clearly associated with things like knowledge about medication, perception of bone health, experiences of fracturing while on medication, pain at the site of fracture, and use of non-pharmacological strategies. But this perhaps mirrors what we found with the quantitative literature and demonstrates why we can't seem to explain very much about adherence in the quantitative literature. So to address the third objective, implications for FLS and the care gap, and I think there are a lot of opportunities here for us. For one thing, we know that the burden of fracture extends beyond 6 months, especially when we're looking at pain. And last year there was a call by COSLA in the Journal of Bone and Mineral Research, published in 2016, to highlight devastating consequences of osteoporosis in order to raise awareness of its impact on the population and the healthcare system. But do we apply that to patients? Do we actually use scare tactics about the burden of fracture to motivate patients to take care of their bone health? Another implication is that I think the communication of terms is often inadequate. We talked about terms like fracture risk, fragility fracture. Fragility fracture is a misnomer. Clearly the fracture is not a low trauma event to patients. Personal beliefs are also difficult to change, and linking fracture to bone health does not mean that you are going to link your fracture to your bone health. And the belief that risk for refracture can be decreased with lifestyle changes only is potentially problematic, I think, if you're not getting enough calcium and vitamin D in your diet, for example. Another implication is that education is not enough. Patients express ambiguity even after being educated through an FLS program, which suggests that we need to talk more about what type of education is needed and what is the importance of better education if taking medication is not associated with perception of bone health. So do we actually need to get patients to link the fracture to bone health? Do we need to reinforce that medication reduces fracture risk as opposed to being related to bone density only? Do we need tailored messages for men versus women? And many of the individuals we've interviewed who report having a difficult time with the decision to take medication have actually done their research, and they have very strong rationale for why that is the case. Is the fracture event a cue to action or a teachable moment for patients? We know it is for FLS programs, but is it for patients? And what do we do with patients who are taking medication? Many FLS programs exclude these patients or don't follow up with them, but a proportion of them indicate that they may change their mind. And we also know that patients don't always return to medication after a drug holiday. Some more implications. Our expectations regarding calcium and vitamin D. Are they too high? Are individuals doing the best that they can given their circumstances? We've talked about how barriers are not just at the patient level and that messages from healthcare providers need to be consistent. So how do we achieve that consistency of messaging within and between healthcare provider groups? And I really think that we need to reinforce that efforts to clarify that messaging has to extend beyond FLS. And finally, just some closing remarks about treatment. After all this research, I find that explaining medication use is not easy. And really, the use of pharmacological and non-pharmacological therapy is ultimately the choice of patients. And another thing I wanted to note is that our results probably underestimate the barriers and challenges faced by patients, because to be eligible for our studies, they had to be articulate, they had to be English speaking, they had to demonstrate no cognitive impairment, and in most cases, they had all received education through an FLS program or other venue. Thank you.
Thank you very much, Joanna. That was an excellent presentation, very interesting, and it's so interesting to hear some of the things that I've heard from the FLS coordinators come up in your research. It's very insightful. So we'll be taking questions from the audience at this time. I haven't received any questions yet, but feel free to type them into the chat box or the question box for Joanna, and I will mention them to her. Just a little bit of housekeeping for those who just joined us. We'll have the recording of this webinar today available on the FLS Hub, which is our website, and you can find that at osteoporosis.ca/FLS. And I will be sending out a follow-up email to you guys as well in about an hour with a survey. We would very much appreciate your feedback on that survey. It'll help us choose topics for the next webinars and improve for next time as well. I still haven't gotten any questions typed in, but maybe, Joanna, did you have any questions for the audience?
I did, actually. I have one question. I just wanted to know whether some of these findings resonate with what you are hearing yourself from patients, whether or not they are your own patients or patients that you talk to for other reasons. But I can't hear if anyone answers my question.
Yeah, we'll give it a few seconds for some people to type in some answers here. So we've got a question here. So Joanna, I'll just send it to you in the text box to Matthew, and I'll read it out. So this question is from Irene. It says, thank you, Joanna. Do you think it would be worthwhile to fortify bottled water or drinking water with calcium and vitamin D in a similar fashion that we have salt fortified with iodine?
Wow, I've never had that question before. I don't know. I'm not sure I'm the right person to ask that question, because the implications for it are pretty widespread. But it is very interesting. It's an interesting question. I really don't have an answer for it because, you know, people will always react to those kinds of fortification. I mean, I know that, I believe in Scandinavia, there was a, and I don't know if this is correct to say, but they didn't have, their dairy products were not fortified with vitamin D, and so for a long time people were wondering why Scandinavians had issues with bone health when they had so much dairy. And I remember someone telling me that once, that it was because their dairy products didn't have vitamin D in them. So it's kind of a similar scenario.
Mm-hmm. So no other questions have come in. So I'm noticing, oh, actually I changed my mind. I got something else here from Tanya Long. So this question's from Tanya. Not a question so much as a comment. I work with the 1-800 volunteers at Osteoporosis Canada. Fear of side effects seemed to me to be the main barrier preventing people from taking meds. An osteoporotic fracture is not as threatening to the individual as osteoporosis of the jaw or atypical thigh fracture or other side effects.
I mean, that I agree with that perception. That perception is definitely out there, even though I know healthcare providers often will, you know, talk about the actual risk of those side effects as being quite, they're very low in my understanding, but patients do still have that perception, and I think that has to do partially with what they're not, the information they're getting not from healthcare providers, but from the media and the internet. So yeah, but that perception, I agree, is really out there and difficult to change.
Mm-hmm. All right. It looks like there's no more questions coming in. This is your last call for questions. Okay, I think that's it for today. So if anyone has any extra questions for Joanna, I'll be sending my email address in the follow-up. So feel free to send any additional questions to us through there. And again, as I mentioned, we'll be sending a survey, so we do very much appreciate your feedback. So thank you very much to everyone for joining us today, and thank you again to Joanna for presenting our webinar today.
Thank you.
That's off now. Thanks again, everyone.